I'm going to go ahead and share my screen. And as Tiana said, if there's any questions, please type them in the chat box, and hopefully we'll have some time to answer them at the end. There'll be some time. This is about an hour or so presentation, and we'll be able to answer some questions through the chat box, and Tiana will be happy to moderate. So really the topic and the title of my talk is Changing Faces, Saving Lives, and obviously it's not my own coined term. I wish I did. This is actually the motto of our association, the American Association of Oral Maxillofacial Surgeons. It came up with this sort of slogan, tagline, marketing phrase that really describes what oral maxillofacial surgeons do. So with that, I am going to basically focus my talk today on the various treatment options that we have to helping patients and making a huge impact in their lives, both functionally, psychosocially, and we've been really privileged to be involved in taking care of these patients. So that's going to be our talk. Ted, could you? I'm getting some feedback. I'm not sure. Make sure that everyone is muted, please. Thank you. So a little bit about me. From Toronto, Canada, originally. I did my undergraduate at the University of Toronto. My parents are immigrants from Pakistan. I was born and raised in Canada, and after undergrad, went and completed dental education at the State University of New York, Buffalo School of Dental Medicine. My wife did the program there as well. She's a year behind, and we both then came to Cleveland, Ohio, where I matched in for the residency of oral maxillofacial surgery. And my former chair, former dean, Dr. Jerry Goldberg, was the one who accepted me in this program. The program involved going to medical school here at Case School of Medicine, completing the residency here at Case, and then which is obviously combined with university hospitals as well as the VA. And then I went on and did fellowship training in facial plastics and facial cosmetic surgery in Salt Lake City, Utah, in a private surgery center there. I've been on full-time faculty since 2000, residency director since 2002. So we're going almost over 20 years, getting on 20 years of being a program director. And I was promoted to full professor in 2018. So we have a wonderful department, which I'll share a little bit. This is the hospital system that my residents rotate through. You'll see various landmarks here in Cleveland. Our new health science and education campus, which is our current location for all the undergrad, I guess undergrad meaning the dental students and medical students before they go into the clinical years. You have the Seidman Cancer Center just in the center place, which we interface with our head neck oncologists and hematology oncology teams. The VA hospital, we have an affiliation with Metro Health Hospital as well, and this is Rainbow Babies Hospital here. And you can see my arrow, I think. I'll be using my arrow quite a bit. And the University Hospitals, Cleveland Medical Center is the main campus that our residency is run through in terms of our graduate medical education. So these are the various institutions. We do have an affiliation on the horizon with the Cleveland Clinic as well. We're just expanding that aspect of the oral maxillofacial surgery program there. And so hopefully that'll be something of the future. So I'm really looking forward to that collaboration. Our department is led by Dr. Dale Bauer, who I've been very fortunate to be under his department and his leadership as we've transitioned over into the new building and a new school. And we have a residency program that's robust with it's a 5-year track. We take 3 residents per year, and we're going to be probably expanding that. And you'll see here on this sort of timeline of education, it's an integrated program with the School of Medicine. This was a program that was developed by Dr. Goldberg, and we've been happy to carry on that torch. The first resident that was accepted into that program was in 1989, and we have been very successful in graduating 2, then 3 residents per year. We're probably going to be expanding to 4, and you'll see that the residents do rotate through a variety of various clinical opportunities. Also at the level of general surgery, which they have months on ENT and plastic surgery in the surgical intensive care units and trauma surgery at Metro. And I'm really happy to boast that we are the only 5-year MD integrated program in the country. I also sit on various committees nationally, and one of those committees is the Committee on Dental Accreditation. And we are the only 5-year program that offers a medical degree in a condensed 5-year curriculum. That's really because of our relationships with the School of Medicine, being able to offer this kind of accelerated, if you will, program, but not taking away the clinical opportunities that our residents have. So really happy about that. If you look at it from a kind of a month perspective of how much time they actually spent in oral maxillofacial surgery, that's the sort of the dark blue. You also see that they spend months on anesthesia. Requirements for accreditation are 4 months. We do 5. We do 1 month of dedicated in pediatric anesthesia training. So pediatric patient safety is critical. You'll see that the number of oral maxillofacial surgery months are on the bottom here. And if you add them up, it comes out to about 33 months. And you only need 30 months of accreditation for oral maxillofacial surgery. So suffice it to say, the program is very strong. Our last accreditation was 5 years ago, and we're due for one next year. And I know this will be my 4th accreditation as a program director. So I don't have any concerns of going forward with our training program. I am pleased to hopefully announce that our program will be able to offer a 4-year track with a science twist. The goal really is to encourage research development and academic surgeons. We've been great at developing community-based surgeons, and some of our residents in the past have gone on to fellowship training, which I'm very happy about. I myself am fellowship trained. Dr. Bauer is fellowship trained as well. But the goal of a 4-year track with a Master's of Science in Dentistry, like the other graduate programs in our school, will be able to offer that additional degree. And we're hoping that in 2022 will be the acceptance of the first applicant to that program next year. And hopefully that will be something that will be on the horizon. So we're looking forward to, it'll be the first new program that the school has been able to offer in a many number of years. So really excited about that opportunity. And we also have a lot of international applicants that tend to want a master's degree so they can go back to their national countries and promote the education of oral maxillofacial surgery. And we would love to influence care in the world. So I'm going to talk about various treatments and surgeries. And so just as a disclosure, there will be some graphics. I mean, as a surgeon, I've obviously going to show some pre and post-op pictures and x-rays, but there will be some graphics. And hopefully, I know there may be some healthcare folks on the Zoom call. Apologize if some of the pictures are a little bit more graphic than anticipated, but hopefully it will be helpful in the discussion. Some of the typical things that oral surgeons do are dental implants, and we do a lot of dental implant procedures, and as do other specialties in dentistry. But there's some of the more sophisticated care implant dentistry, and these are just some of the patients that I've helped over the years, and you'll see that they all have smiles and they're all happy patients. But these patients have really looked for full arch rehabilitation. Now, what that really means is restoring someone's bite, their smile, their self-confidence, their ability to enjoy life, enjoy foods, quality of living, really comes from the oral cavity. And when you have complete breakdown and you have a situation that develops that patients find themselves in a helpless or hopeless dental situation, this is a treatment option that we have been using and as others have been doing. But I wanted to share with you our treatment protocols for delivering full mouth reconstruction in a day, that the patients can come into surgery with their existing hopeless dental condition and come out from surgery that day with a prosthetic, at least that is temporary, but a And these are some patients that you're seeing smiling with their final prosthesis in place on day of surgery. So let's take an example. This wonderful lady presented to me. She is a high-powered VP executive of a bank, and from glance, it looks like she's got her dentition seems to be intact. But if you further look at her details, she's got crowns and bridges, bridge work, that underneath all that, the substructure that they're held onto is failing. And when you take a closer look at her oral cavity, and again, not to go into a full, complete dental lecture, but to show that there is breakdown along the gum line, there's active disease. These are the natural teeth that they're kind of darker in color. The artificial teeth that she's had, bridge work and crowns, are all sitting upon teeth structures that are failing. So here's the X-ray, and you can see from the X-ray, there's lots of root canal fillings, there's decay, and really this has become a situation for her, and she has lost some back teeth as well, that she really needs some more support to be able to function. And in her situation, she does not want to go without teeth, not for a single moment. So our options are what? Back in the days, I'm talking about even 10 years ago, though, maybe even 15 years, we would have to take out the teeth. We could place some implants, but those implants could not be attached immediately because we didn't have the technologies to be able to put the implants in the right spots, to be able to fabricate a dental prosthetic that would be comfortable for her to wear immediately, that she could function, at least smile without having to wear something that was a removable appliance or a removable prosthetic device. So this patient is a prime example of what we call somebody in a hopeless dentition, terminal state, whereby the teeth need to be removed, but we don't want to give her a prosthesis. We want to give her something that's going to be something fixed that she doesn't have to take in and out, and she can wear comfortably. So the treatment this is just a schematic of what we are talking about. This is called all-on-4. And what the all-on-4 protocol is essentially is placing implants as close to the sinus. The maxillary sinus exists, and I go back on the X-ray. Maxillary sinus is this kind of dark circular pattern area on both sides, and the bone typically ends of the upper jaw where the maxillary sinus begins. And so by virtue of making an entry point into the maxillary sinus, we can identify where the bone ends and then drill into the bone with precise, fine drilling instruments that will be the size of the implants. And this is all predetermined ahead of time based on certain x-rays. So this is what we're going to plan to do for this lady, is place implants, at least 4 of them, and that's why it's called all-on-4. It's a protocol for anchoring, like a chair has 4 legs. You can anchor a prosthetic comfortably with 4 implants equally. Now we can take digital models now. So this is an impression of another patient, an impression of their teeth, looking at the full mouth reconstruction. This information is then sent to our lab. So this is the device that we use. Again, I have no disclosures and no financial disclosures to claim today on any of these devices that I'm going to be talking about today. And the use of CAT scans, 3-dimensional radiography, can mirror the image of the teeth along with the bone scans. And this is a maxillofacial bone scan called cone beam CT to evaluate the bone structure, where the best bone would be to place these implants in a successful situation. The software design companies then use all this data and start planning the case for me, in that I go online with them, just like we do with a Zoom meeting, and I can see where the implants are placed relative to where the teeth need to be. Now you'll see that there's 2 sets of teeth. There's a brownish set, which represents the patient's physical model. So this is a digital model of the patient's teeth. And the green represents the planned prosthetic that's going to be made ahead of time, delivered to us before surgery, so the patient can leave with this in their mouth. And you'll see that we try to pick teeth. The green is a prototype that somewhat mirrors the size of the patient's own teeth, so that we can get an accurate representation of what the patient is going to be leaving with, and it'll be very much matched to what they came into the office with. So they'll go to sleep with teeth in their mouth, surgery will take place, and they'll leave with teeth in the mouth anchored on these dental implant bone supporting devices. So further detail about the planning tells me how much bone will be reduced and trimmed away. The implants are planned in a fashion that is best conducive to adequate stability and function and structure over time. So we want this to last a patient's lifetime. This is various just views of the scans and how bone, that the implant is going to be surrounded by bone on all sides. And that gives us high chance for success. So here's some of the graphic slides. This happens to be the slide of another patient, but where the teeth are removed. These guides are printed ahead of time that allow us from the previous software design plans. It's all then translated into something that's more analog, and we then use it in surgery to fit everything. So the implant teeth are removed. The bone is then trimmed down, as you can see, and then the surgical template is then placed on top, and implants are placed through the guide sleeves in the exact direction, angulation, and depth control. So three-dimensional placement for high accuracy to allow for this case to be restored. So this is what she started with. This is what she ended with in terms of the implant positioning. And this is what she looks like 1 year later. So you can't even tell that this is a prosthetic. If you looked inside her mouth, you would see that there would be a transition line. But when she smiles, she will not be able to show this transition line where her gums end and where the prosthetic begins. You can see some of the metal. That's inevitable. And taking the prosthesis off, you'll see that the tissues respond very well. And the bridge that we like to call this prosthesis, it's a full bridge with no palate, unlike a denture that somebody would leave with. And so this is a very nice and comfortable position. Let's talk about a more extreme case, a patient who comes in also looking for prosthesis. Now, in this case, this patient has been living with a prosthesis, an upper prosthesis, a denture, has lost her teeth for over 50 years plus. So she had them removed when she was younger, and all they gave her at the time was a denture prosthetic. So now we have a situation where when teeth are removed, we know biology takes place. The bone begins to shrink and absorb and resorb, and therefore now we don't have the bone to place these implants. So what can we do? So we're going to talk in this case about, this is a schematic of showing that the upper jaw bone should have been down where the teeth used to be, because that's what the teeth are. That's where we want the prosthetic to be. So we have this sort of gap, and this is what it looks like in the mouth, but there's a gap between the upper and the lower jaw, because we know by virtue of mechanics of your bite, the upper jaw is outside or in front of the lower jaw. We don't have underbites, we have normal bites. And so in order for this patient to have implants, we need to replace the missing space with a bone or bone graft material. So let's talk about that option. So in this case, we're going to use the patient's own bone, but we're also going to move the upper jawbone forward so that the relationship between the upper jawbone and the lower jaw is back to normal. It's shrunk because of loss of teeth, but we know that we can't put implants in like this. We have to actually bring the jaw forward. And this is what the surgery is going to be showing you. This is a cut inside the mouth. And we're going to be doing a jaw repositioning procedure. We're going to be taking bone from the scalp, or actually from the cranium. We're going to take bone from the hip on this lower left picture. And we're going to take what's called PRP, which is platelet-rich plasma, grind the bone together and create bone material along with and these bone struts that you see here as we see blocks. And then the upper jaw will be repositioned with the use of plates and screws. So now we have a proper position and thickened bone for a foundational reconstruction. And this happens to be this cone beam CT of the new bone graft and the new jaw in the right position. Now we have a foundation that's going to be healing for about 4 to 6 months. and then dental implants will be placed in this newly bony foundation area, and that's what this slide shows. Now, this particular patient, because they came with a denture, they probably could have opted for a non-denture situation, but in this case, we did create, and we work with a team of dentists and prosthetic specialists. They're the ones that create the prosthetics for us. We place the implants in the correct location. So for whatever reason, this patient opted for a denture that could be attached to the implants and then removed at night for cleaning purposes. And this is her without the denture. This is her with the denture in place. And you can see the amount of soft tissue fullness that we help to recreate by the bottom of the nose and a better facial profile. So, what if a patient opts not to have bone grafting or is not a suitable candidate for bone grafting for medical reasons? We do have some other tricks in our sleeves using different types of implants that have been developed specifically for patients that don't want to have or can't have bone grafting. These are the use of these longer implants called the zygomatic implant. Now, the zygomatic implant is based on the name called zygoma. Zygoma is the cheekbone, and this is a diagram of our anatomy, the nasal cavity in the middle, the sinus cavity on both sides, and then the cheekbone out here. And these implants, they traverse from in the mouth all the way through the sinuses and into the cheekbone, all from an intraoral approach. That is, we place these implants from inside the mouth. We don't place these implants from the outside or through the facial skin. So this next case now, well, this is what the implant looks like, just to show it's very long. It can come in various lengths from 30 millimeters to 50 millimeters. And the diameter of the implant can be 4.1 on the platform, and its thickness gets narrower as it goes deeper into the bone. So we don't have this big thickened screw, but we're talking about very small diameter implants. So this patient presents to me, she again, a younger patient now, had all her teeth removed at a very young age. Again, the result of tooth loss at an early age is bone loss. The denture she was presented with doesn't stay anymore. There's no bone to hold the denture in place. And so she comes in as a quote unquote dental cripple looking for help. And for us, this is a great opportunity to be able to help the quality of life for a patient like this with a zygomatic implant concept. So this is what the ridge looks like, extremely thin. That's the remainder of her lower teeth. They will be removed as well. This is what the palate looks like. On both sides, you can see how thin the bone is. And from an X-ray point of view, it's like a pancake. There is no thickness to the bone. The only bone that we can capture is the bone by what we call the zygomas of the cheekbones right in this area. So with the use of 3D technology, we can then evaluate the structure of the cheekbone, the structure of what jawbone exists, and be able to place the long implants through the mouth, past the sinuses and into the cheeks to create anchorage or support for the prosthetic. So this is what it looks like in the mouth. This is the tissues exposed. We make a hole in the sinus cavity, and this long drill will drill through the bone of the mouth into the cheekbone to be able to place our long implant anchors right through. Okay, so that's the depiction of that. These are the 4 implants placed in her minimal bone quality. That's what it looks like on the X-ray. And then teeth will then be pre-fashioned and attached to these implants either the next day or the week after. Sometimes we'll wait depending on the quality of the bone, but it can be done as an immediate as well. And that's what the final prosthetic looks like. Some of you are wondering, well, it's so darn thick. Yes, compared to the previous patient, the more bone you lose, the thicker the prosthetic is going to be if we're going to use implants to support. The implants are strong enough to hold the prosthesis. the prosthesis needs to be thick enough and rigid enough to be able to withstand the forces of eating and chewing. And if they're too thin, they'll break and crack. Also, the implants are placed more palatal or more on the roof of the mouth because, again, of the shrinkage of the bone. That's the only place that we can access the patient's existing bone without bone grafting. So, again, another solution for a result that gives a patient that comes in like this and can leave with a final result like this. And she looks younger just by virtue of tooth replacement with a prosthesis. So we know that the dental replacement, the teeth replacement helps to support the collapsed soft tissue, but also support the loss of the bone that supports our lip as well. Here's another patient that presented to me, and this is actually a case that we actually had published in one of the case magazines. We were fortunate to have that. This was a patient that was presented to me as a charity case. Because of my parents and our ethnic nationality is Pakistani, I'm involved in the American Association of Pakistani Physicians of North America. They have a dental chapter as well. And through that dental chapter, I was approached to help treat this individual who was shot by the Taliban, I believe in 2016, where the Taliban entered the schools and just started shooting all the students. He was a survivor. He ended up having gunshot wounds to the face and to the mandible. He was immediately treated in Dubai, in the United Arab Emirates, for emergent care, and was left essentially with implants on the bottom, which was fine, placed well, and bone, and then there was some titanium hardware, but nothing was done with this top. And the maxilla was extremely lacking in bone, and they didn't know what to do. And somehow I was lecturing for the group about 3 years ago, and my name was circulated, and I was fortunate enough to be put in touch with this individual. He then came to the United States on a visa just for care, for the care of this and our university. And I'm proud to say that we were able to help him without any cost to the patient, other than some of the ancillary anesthesia costs from the hospital that we utilize. But we were able to give our services for free to help this individual in this care. So let's talk about this case a little bit. Upon my examination, we did need the help of a prosthetic specialist. So we had a former faculty member, Dr. Fadi Fadul, who's also an alum of our institution, and now he's in Texas. So Fadi was very helpful in this case as well. So I wanted to acknowledge his involvement. But between Dr. Fadul and myself, we were able to come up with a plan which necessitated the removal of the remainder of the teeth that remained, and then doing some bone grafting and rebuilding the bone, and then placing some implants. And so we also used that same zygomatic implant to attach and some implants in the anterior and the front. And there was no bone here, but there was also no soft tissue to be able to place any implants in this location. But however, we only needed 3 implants to be able to give this patient a full set of back teeth that were fixed in position that he could eventually function with. And so this has been really an amazing case to be involved in from a reconstructive aspect, and then also from using technologies, updated technologies to provide a prosthetic that was fixed on a young individual that will last him his lifetime. Another patient that presents with a situation like this. So here is a patient whose lower jaw, because of the loss of teeth, is extremely fragile and thin. Now, some might say that, well, the front of the jaw is actually pretty strong. The back of the jaw is not. So she cannot have implants in the back. And really, there are nerves in the jaw that we can't place implants. Otherwise, she would be numb in her lip and chin for a lifetime. So this patient underwent bone grafting Well, actually, before I get into that, we're going to use a different type of implant system that is new called the trefoil. It's a 3 implant system with the surgical planning can give us a bar on 3 implants instead of 4 or 5 and be able to create a prosthetic within 1 to 2 days as the final prosthetic for this patient. And so this patient will have implants placed in bone that's been grafted. This graft is done from the hip bone. So this is what you're seeing. Hip graft is being done and completed. We come back in after 3 months, and the implant bar that you see on the previous schematic is in place and just basically housed on 3 implants. And this is what it looks like from an x-ray. And this is her final prosthesis 1 week after surgery. She does not have to wait. She can function right away. And she is, ecstatic that she can wear something that she can bite with. She does have an upper denture, but that seems to be okay for her for now. But this is again, a new concept, an implant dentistry, creating on 3 implants instead of the 4, something called the trefoil bar immediate reconstruction. So really, a really good treatment option for people of the lower jaw coming in as being edentulous. So that's really some information and some examples of patients needing a full mouth reconstruction with dental implants. Let's talk about facial trauma. And of course, facial trauma is something that's near and dear to maxillofacial surgeons. A lot of our surgical principles and treatment of care, elective surgeries are based on the handling of patients in facial trauma. This is a young gal, unfortunate accident, dog bite. Unfortunately, we do see a lot of dog bite injuries here in Cleveland. But this case really saw the removal of almost 80% volume, actually more, 90% volume of her lower lip. And this becomes a very challenging reconstructive scenario on how to create a lip that's going to be somewhat normal. How are we going to create the opening of the mouth to be normal, that we don't close the mouth and cause oral constricture, inability to open the mouth and tightening. So we use some treatment options taken from our oncology colleagues. We did what's called an Abbey flap. And this is basically a flap taken from the base of the nose and the upper lip. And we flip the upper lip down into the lower lip defect. And this patient is now sealed like this for about 3 to 4 weeks until healing takes place. So in essence, what we have done is we've stolen tissue from the upper lip, rotated it to the bottom lip, kind of like what we do with cleft lip and palate children. And we sit on that team, and a lot of our colleagues are involved in cleft lip and palate care. But this essentially is transposing tissue from the upper lip to the lower lip in efforts to recreate the loss of volume. We then come back after 3 weeks and 4 weeks of healing. You can see the scars are just immature, but there's no sign of infection. So we can go and then remove the tissue and then disconnect. Now you'll see that the upper lip has lost a little bit of length because obviously we stole that length to rebuild the lower lip. And this is the patient after about 3 months of healing after the disconnection. So you can see that there's a little bit of asymmetry in the Cupid's bow. And so now we can use some artificial fillers to help recreate the volume. And so she comes from this position to something like this, which even though there's still a little bit of a pull to this patient's left side, the nose is also shifted to the left. We can then offer a little bit of scar revisional surgery to release the tension of the pull to at least make it a little bit more in midline. But at least the patient has a fully functional lower lip from procedures that we would never have thought of unless our oncologic surgeons would have, we wouldn't have training with them. Major trauma. This patient, again, Funny to say that he is also another UAE patient. He was life flighted into our hospital. We accepted the transfer. He was stabilized in the actually he was a Dubai soldier or police officer, and was stabilized there for some reason. Not sure why the UK didn't accept care, but he was then sent to us. But if you look at the three-dimensional CAT scan, you'll see that there are all these fragments of bone up in between the orbits, fragment of the upper jaw. You can see the tilting. You'll see that the face is completely skewed over to this patient's right side. There's flattening on the right side. There's fullness on the left side. All sorts of fractures. And this is something that we do a lot of it. And our level 1 trauma center here at university allows us to take care of these patients with a full team of surgeons. This patient, we ended up doing a tracheostomy, which is a permanent tube, while his swelling was under control. And we are now utilizing various forms of virtual augmented reality to help locate the fractures prior to surgery. So with the use of companies like Zimmer Biomet and immersive touch software technology, if I can share with you this little diagram of me playing around in the virtual space, I can actually look at the fractures, and I'm looking at them through my Oculus, but this is what the computer screen looks like. So I obviously can't show you what I'm seeing, but this is what the computer sees, what I see in the 3D space, looking at bone fragments and fracture patterns. And this is a really great teaching tool for my residents in terms of diagnosis and then also sequencing of treatments prior to even going into surgery. So it's been a really wonderful piece of technology. This is what it looks like, kind of look a little crazy with the headgear on and just moving my hands around, but the computer screen is showing you what I'm doing. So this patient then underwent surgical care. All the placement screws and the fragments were then reapproximated. The bite was then reestablished. The mandible was treated. And you can see this is about 2 weeks. He's still in hospital because of the severe brain injury that he suffered. So he ended up going to long-term rehab. But you can see the symmetry of the nose and the cheekbones because of the restoration of the 3D volume of this patient's maxillofacial region. So let's talk about orthognathic surgery. So trauma surgery obviously is unpredicted. Fracture patterns of the upper jaw, the mandible, the nasal bones. When we want to actually make accurate cuts in the bone and recreate a bite or fix a bite, we term that as orthognathic surgery. Orthognathic surgery is also called corrective jaw surgery. It really is treatment dedicated at the bite itself. And we'll talk about a couple of severe cases of bite surgery. This is a craniofacial patient of Cruzon syndrome. This patient has midfacial hypoplasia, complete underdevelopment of the cheekbones and the orbital bones. But you'll see that the frontal bone is completely developed as is in proper position. So we term this in terms of the levels of the disease. This is a level 2 or Lefort 2 level of hypoplasia or underdevelopment. But not only that, this patient has a severe midface development in that she has a huge underbite where almost her upper teeth, her front teeth actually, are touching on her back teeth. And so it's very difficult to see from this photograph, and I apologize for that, but the discrepancy or the difference between the upper teeth, the front teeth, and the lower teeth is almost 20 millimeters. Well, when you have that kind of discrepancy, it's very difficult to physically move the bone and hope it stays in that position with that kind of movement. We can do it great for 10, 12, 13 millimeters, but for 20 or 20 plus millimeters, it's very unpredictable. And we have what's called relapse or a slip back situation. So this patient was a great candidate for distraction osteogenesis. And what distraction osteogenesis does, it is a procedure like they've developed for leg bones. And in leg lengthening surgery, we would turn the device and the leg would lengthen with the increments of change over time. And this is the same thing that we're doing with the mid-facial skull of the face, that we make the cuts, we put the device on in the operating room, and the family is required to turn. You see there's 4 little screws on the device to turn the device to actually bring tension, and tension allows bone to be placed behind it as you get bone growth under tension, and then the jaw would stay in that position. So this, because of the discrepancy of the large movement, we did distraction osteogenesis. This is her after the device was removed 4 months later. And you can see relative to the frontal bone, which was in normal position, we didn't touch that, how the orbits now have good volume and soft tissue support. There's still some, some other corrections that will be done later on, but her upper jaw is relatively in close position. Now the lower jaw looks like it's far behind, and so she'll undergo a second operation for orthognathic surgery. So she goes from here to this position on the right. First surgery, second surgery to recreate the lower chin and jawline. That's the lower jaw surgery, and then a little readjustment of the upper jaw. And then I know Dr. Wang might be on the call here. Dr. Russell Wang, our maxillofacial prosthodontic specialist here at Case Dental Medicine, did beautiful veneer work for this patient. We also did dental implants because she was missing some permanent teeth. And these are some implant photographs. So you have this patient who, may not have had a great outlook on life, a huge psychosocial effect. She has hearing aids. And I can tell you that I still follow her now. She's a mother of 2 children. She's in her mid 20s now, actually late 20s. And this is the kind of results that we hope to achieve for all of our patients, to allow them to function in society as a normal human being. So really privileged to have been involved in a case like this. Here's another case of a severe craniofacial patient. And this was also in one of the Case Dental Medicine magazines a couple years back. This patient had a severe muscular dystrophy condition called Memoline Myopathy. It's a disease of muscle origin, of basically, not to get too scientific, but the ability of muscle contraction. This patient was referred first by Dr. Mark Hans, the chair of orthodontic department, and then taken over by Dr. Manish Valyathan, the director of the craniofacial orthodontic fellowship program here at Case. So this is, again, a collaborative effort on helping this patient get into some normal condition. She had multiple surgeries leading up to her final operation, so I won't go through all that. Suffice it to say that we did a lot of expansion surgery, a couple of upper jaw surgeries to get her into a proper position, and then the final jaw surgery. But if you can see, she is unable to close her mouth because her teeth interfere first. That's one aspect. The second aspect is we don't know, because she has a muscular disorder, we don't know if she can open her mouth and hold it closed even if she was able to. What you don't see from this photograph is this person is on a ventilator. She is on a wheelchair. She has very minimal activity of her chest wall, so she can't breathe appropriately. So she has a ventilation that, as she inspires, it actually will give a puff of air into the lungs. So she needs some respiratory assistance to live. Amazingly, she is hyper-functioning in that she has a smartphone she has a smartphone and a pen on her wheelchair, and she can type and text in full sentence structure. You wouldn't imagine. She cannot speak. She can't put her lips together to seal, to even make any sort of sounds, sibilant sounds, or at all. So incredible. This is what she looks like before surgery. She has this huge overdevelopment of the upper jaw. The lower jaw is wickedly developing downwards. I'll show you the CAT scans to show that. This is what the bite looks like on various photographs. This is her CAT scan. Believe it or not, she does have joints or full development of the entire bone of the mandible, but it's almost like in a straight line from bottom to chin. And so we're going to try to recreate a new angle to help close the bite and then help reposition the jaw by jaw surgery. So how do we do this? We do it with surgical planning. This is called VSP, virtual surgical planning, using technology and guides to accurately make cuts in the bone so we know exactly how the bone segments are going to fit. The only thing that the planning doesn't help us with is how the overlying soft tissue, muscle support, and the muscle drape, how it affects us to be able to move the bones, because the bones aren't existent without muscle. And muscle attaches to the bones, and we have to sometimes release those muscle attachments to be able to move our jaw into the right positions. So this corrective jaw surgery, we were hoping to have an outcome that looks like this, which would be a very reasonable outcome for this patient. This is intra-op right before going into surgery. This is actually on the table, so I don't have all the slides to show the nuances of the operation. I have it on a different lecture. And I overlaid my virtual surgical plan on the patient's picture. So if you'll see that again, we were pretty close, and you can see the transparent outline of the plan behind it, really close to our plan. So it was really ecstatic to see that we were able to get to that. So this is our patient pre-op. You see, she can't close further than that. Oops, let me show you the, oh, I'm missing the post-op. I apologize. I'm not sure why it didn't come through. Oh gosh, darn. But this is what she looks like afterwards. I mean, her bite's closed. She can open and close her mouth. It was the first time she actually said mama. And that day when her mother was in the room and she was able to kiss her mother for the first time was just a sight that I'd never seen and had never felt before until that day. She actually has a Facebook support page. It's called Andrea's Miracle Surgery. If anybody wants to look at it, and you can see all the various comments. This is way back from 2018. I have now spoken for this group of Memoline Myopathy patients. You'll be surprised they have a full support group. There are many kids and young adults that are suffering from this condition. And I was fortunate enough pre-COVID 2019, I spoke at their annual conference, and hopefully I'll speak again to them. But I've been really fortunate to have been involved. This is the article from the AOMS journal. So this is a technology using 3D and the planning that you saw, but now we can make the virtual simulation as a mask to allow the patient to visualize what their profile change is going to be after corrective surgery, because we know that we're correcting the bite, but we're also going to be changing the aesthetics of the patient's face. And I think that's very important. I'm very pleased to say that I'm the first maxillofacial surgeon in the world using MirrorMe 3D, and I'm going to sit on their board now for the innovation advancement of this technology for maxillofacial surgery. So we use it in conjunction with Stryker and 3D systems. This is the patient, same thing you just saw, holding the mask in place. This is actually on the operating room table after the surgery, and how we've been able to accomplish our results using the mask as a guide in the operating room. Again, a couple other examples of patients that we've been using this mask on has been really helpful. Has been helpful for patients to visualize and accept treatment, and also be part of the care. So really excited. In terms of corrective jaw surgery, I really term that as bite surgery. But TMJ is the joint of our lower jaw. And oftentimes these patients will have developmental problems with the jaw joint, as well as problems with arthritic issues, wear and tear, and also congenital jaw problems called juvenile rheumatoid arthritis. I just got a text from my mentor, Dr. Goldberg. Thank you, Dr. Goldberg, for that wonderful message. So here's a patient, she's 16, and she presents to us with this condition already diagnosed by her rheumatologist. And this patient presents with significant chief complaints of pain, unable to function because of pain, but also severe sleep apnea. And you'll hear about sleep apnea a lot because it is a condition that is directly impacted by the position of our jaws. And if the jaw is underdeveloped or starts to deteriorate because of an inflammatory arthritis, then the jaw falls back. If it falls back, you can see that you can imagine her airway, which is back here behind your jawline, behind your angle is your airway. The airway gets pinched, and that pinching, when you fall asleep and lie backwards, can cause sleep apnea or blockage of airflow. So she has all these conditions. When you look at the joint, you see that the joint is completely macerated. It is malformed. It has disintegrated essentially, and the bite has opened up because of the jaw slipping over time. So this patient needs not only bite correction, but TMJ replacement options. So prior to using, what do we use to replace TMJs with? Well, back in the days before use of implants and hardware, we would replace joints with patient's own tissue. Dr. Goldberg, we all were trained using rib grafting very routinely. There is morbidity involved with that. We have to take it from the rib cage. Usually it's the fourth or fifth rib. You can get a pneumothorax or a hole in the lung from taking the graft. We do it ourselves. If it's a younger patient, the rib can grow and overgrow. So lots of different variables that might not be the best tissue of choice. But since the late 90s, we've been using alloplastic or implants that are implantable devices, and they're custom made. In fact, since Dr. Goldberg is on the call as well, we did the first custom made joints here at our institution by bringing Dr. Louis Mercuri. He was the inventor of TMJ concepts. This is 1998 now, and that patient, I still see her, routine follow-ups, and has done quite well. So we've been doing now TMJ replacements for patients with these problems. This is using the technology, what we saw earlier with cone beam scanning, getting the bite relationship corrected, and then you'll see that there's this big gap that we can use to then pick out implants. Now, furthermore, in technology, we use TMJ concepts that's custom made. But what if we have a trauma case, or we have a case that requires immediate treatment? So custom implants require about 3 months to be built. In cases where you need the patient to be treated immediately, we can use what are called stock implants. Now, stock implants come in small, medium, and large for the sake of discussion, but we can now plan our stock implants using technologies to pick out our implants. Custom implants are made with typical wax patterns and then casted into their appropriate materials and metals. But custom implants, again, using virtual reality, and I will show you a quick video of using customization of TMJ implants. And the only one that has these non-customized implants or stock implants are Zimmer Biomet. And this is using Zimmer Biomet templates on the scan. And I can pick the size that I want based on the patient's normal anatomy, looking at the virtual space. And I'm doing a case like this tomorrow. So this is actually that case for tomorrow that we're going to be planning. So some surgical cases. This is the placement of the components of the TMJ. This is up by the ear, and this is a component of the TMJ by the bottom of the neck in proper position. This is the customized hardware for the upper jaw. So now we don't even have to pick out plates and screws. This is custom made for this patient. We just put it on, fits like a glove. And this is our before and after profile. This is about 2 months afterwards. She still has some edema, some swelling, but this is 2 months after the correction. Braces are off, and it's almost like a totally different person completely. And she's so happy with her results. This is her profile view. Her sleep apnea has been corrected. This is the scar that you can see will completely fade after about 6 months to 1 year. And we can do some scar management with our facial cosmetic techniques. This is the implantable device in place. And this is her in prom. really just has turned her life around. She also is blogging now. She's created a video blog on YouTube, so you can look her up. She has an Instagram page, and she's actually sent a lot of patients. This is back in 2018, January, you can see. But she posts her own photos. I mean, just amazing that these patients can tell their stories and be really proud of going through something like this. Here's a testimonial of a patient. So this is, again, we just did her probably about 6 months ago. This is back in January that we taped her testimonial. Again, this condition does exist, and so it's really really great that we can help these patients. I know I'm looking at the clock here, so we have just a few more things to talk about. Facial cosmetic surgery. This is my fellowship trained area, but this is looking at soft tissue changes now. This, everything we talked about now have been mostly been facial skeleton. So having added training in the soft tissue envelope and then treating these patients from an aesthetic point of view has been really helpful in my practice. This patient, came for just a routine neck lift, neck tightening procedure, which can be done from a simple face and neck lift. Again, using technology to our advantage. This is a 3D simulation of how we can show patients results. Let me just show this to you a little bit. This is a patient undergoing rhinoplasty work, chin implant work, lower eyelid restructuring, fat grafting, and you can see the changes right on the screen so the patient can appreciate the change. I'll just fast forward a little bit. You see the nose, the profile, and then the under eye appearance. And we can just play around with the software to give them a realistic view of what to expect. Again, really been helpful in the practice to offer this kind of visualization for patients to accept care. So this is just liposuctioning. You can see just a little surgical photograph so you can get a flavor of when you do a neck lift and a facelift, liposuctioning is done. And this is the skin being redraped over top after we pull it up and over, and we can remove the extra skin tissue to get the kind of leveling of the skin. And this is what the patient looks like immediately 3 days, 4 days after surgery. This is a different patient with a neck lift. You can see the amount of bruising and swelling, but they're not in any pain. And they're very ecstatic about their procedure. Pathology. We do a lot of pathology in and around the jaws, and this happens to be a young patient. She's actually 17, 18 years old with this tumor called ossifying fibroma, an aggressive benign tumor, but would require a complete removal of this tumor. We can do 3D planning to give us the models that will help us to plan. We can use guides fixed over the models where we're going to actually make cuts in the bone and remove this tumor bed. Again, surgical slide of the tumor being exposed. Visuals of the protocols to cut the tumor out, and that's what we're left with. And then we can create a plate that will give her the same shape of her normal jaw, but this is just the plate holding the jaw in place. So this is how she's going to live for about 6 months until we reconstruct her with bone grafting. This is what the X-ray looks like with the tumor removed and the plate in place. And this is now 6 months later, taking bone from her hip, the back of the hip actually, for this amount of defect. This plate is a new plate, which mimics the shape of the jaw. And this is the amount of bone that we're going to rebuild. You can see the height, and future implants will be placed to give her a dental prosthetic that you saw. So now we're combining approaches from the first part of our lecture for dental rehabilitation with patients who actually have missing jawbone because of trauma, because of benign jaw cancers. This is a case that we worked alongside with our ENT colleagues. I think this is the last case we'll talk about. This happens to be a malignant disease where this was resected, and the tumor surgeons, we work alongside with them. This happens to be the leg bone, and planned on a computer screen. We're able to place implants prior to the leg bone being placed. So unlike the last patient where we had to wait for 6 months, then place implants, then wait, this is done as an immediate reconstruction with dental implants. So this is the leg bone on the table with the implants placed with all the planning software. This is what it looks like immediately placed by the ENT surgeons. I came in just to do the implants, and this is what the patient looks like 6 months later. And then this prosthesis then will be fixed on these implants. So I've talked, quite a bit about various different aspects of how we save the faces and change the lives, or change faces or save lives, however you want to say it. This is my family. I wouldn't be here without their undying support, and my motivation for what I do every day is through the love that I have from home. So I want to thank you guys for allowing me just to share a few moments with you of the kind of things that we are privileged to do and help these patients. And I want to thank the institution for giving me this opportunity. Thank you very much.
Thank you, Dr. Quereshy, very much for that. That was amazing. Some of those results were just crazy. So I wanted to go into a few questions that we had, some that were offline, as well as some that have come in through the chat. So one that we want to start with, we go from Michael Simba. For total joint replacements, do you have to reattach the lateral pterygoid?
Pterygoid. So this is a scientific question.
Thank you. Pterygoid muscles to the prosthetic condylar head.
Condylar head. Yeah. Okay, so I'm going to simplify that, since we may have some other non-dentists on the call. The question he's asking is, when we do total joint reconstruction replacement, there are muscles that are going to be detached from the area of the bone that is removed. And so those muscles are not reattached back. So that's a great question. One thing that we do tell our patients after total joint replacement, that they'll be able to open and close their mouth, but they will not be able to go from side to side, and they won't be able to move their jaw forward. Now, you might think that, oh my gosh, that's going to really limit or impair their quality of life. And you saw that patient, she's, without asking her, does that bother her? If you don't ask them, they don't really notice a difference. They're just worried. They just want their pain to go away, and they want to be able to open their mouth and be able to chew. Now, we do need to use our jaw to chew from side to side, but we're not like other, herbivores. Herbivores actually chew from side to side. Grass-eating, animals, we don't chew like that, but we do chew a little bit. So our pattern is up and down and a little bit of lateral. But the little bit of lateral that we lose in total joint replacement is inconsequential. We did a paper on quality of life, Dr. Bauer, myself, one of the previous residents, and you can look it up. I can't give you the citation offhand, but in the Journal of Oral Maxillofacial Surgery, quality of life, QOL, for total joint replacement. And I think that was one of the parameters we asked. A good question.
Thank you, Dr. Quereshy. This next question was from Mitchell. With Andrea's surgery, how was the inferior alveolar nerve maintained? Right.
So when we did our virtual surgical planning, our cuts, you probably didn't, I'd have to go back to that slide to show you, but we made a horizontal cut and then a vertical cut. It's called an inverted L osteotomy. And we typically make that cut above the opening of where the nerve enters into the canal. So we don't actually damage the inferior alveolar nerve at all. We cut around the nerve, so that alleviates any chance for lower lip numbness and paresthesias.
Thank you, Mitchell. Thank you, Dr. Quereshy, for that. One of the offline questions we received, after you graduated from CWRU, was there any additional training that you received to be able to do some of the surgeries like you did with the patient from Pakistan?
So after graduating, having gone through my all my residency and fellowship training, all of my residents are pretty much exposed to all the surgeries that they see. So they're very comfortable. Some of them may or choose not to do some of the surgeries that that I showed only because of lack of interest or what have you, but they all have the surgical skill set to be able to do that. We're learning every day. I'm learning new techniques from colleagues, from people who are more innovative than I am. I wish I was an inventor. I wouldn't be sitting here. I'd be retired somewhere in a nice place other than snowing in Cleveland, Ohio. However, um, but having the exposure to different technologies has allowed me to expand my delivery of care. I think that's something that our residency program allows my residents to be able to do, is they give us the surgical tools to be able to do whatever you want with it and take additional courses and fellowships that they feel. I have a lot of residents that go on to additional fellowship training in head and neck cancer last year, and I have some people who've gone and done cleft and craniofacial training. So there, the options are limitless for what you want to do.
Dr. Quereshy. Does anyone else have any questions that they wanted to drop into the chat? If so, I would be happy to facilitate those. I know Dr. Lim asked some questions. They were more in depth. So Dr. Lim, Dr. Quereshy, or myself will connect with you offline via email to provide you some better answers for those. Okay, well, if we don't have any more questions, I would just love to thank Dr. Quereshy for his time this evening. It was a phenomenal presentation. You were a phenomenal presenter. Thank you so much for taking this evening with us. Like I mentioned earlier, if you signed up for continuing education credit, you should see those certificates in about 30 days or so. But also, we'll be sending out a very nice survey following this event. So we'd love some feedback and everything. And we hope to see you at one of our events in the future, and that everyone stays safe.
Thank you again, Tiana and Sarah. Appreciate it.
Thank you. Have a great night, everyone.